Now do record. Share. All right. First of all, as we start off this week for genitourinary, does anybody have any questions? Not right now?
Not right now.
Okay. All right. And you guys saw my recorded message yesterday about the exam. You guys rock that. That was not an easy exam, and you guys did a really, really great job on that, so thank you. I received several emails about that infamous question number 24, but anybody that had number 5 marked wrong, I just gave you the point back. And if I found that you had number 4 and number 5 mixed up, I actually gave you back both points, because if 5 wouldn't have been screwed up, you would not have put that. So I gave you guys all benefit of the doubt, if that is what you guys had on your exam. Does that make sense?
Mm-hmm.
So very fair with that. Really high marks on the exam. And your discussions that week were phenomenal. What did you guys think about learning about what you did about marijuana?
I was actually pretty surprised about what I learned. I knew that I'm at Denver Health Urgent Care right now, and we've had a bunch of people come in with kind of, acute symptom use things going on from marijuana use. But I was pretty surprised about some of the studies, like the long-term effects, and the IQ was really surprising. So I thought it was really good to know all of that.
That is a good point. Who's speaking next?
That was me, Joy.
Okay, Joy.
Sorry, I talked right over you.
Oh, it's okay.
I actually shared the IQ dropping 8 points with a pediatric patient that I had.
Oh.
And so, because they were just talking about it and asking about it. And so I got to share that information.
That is really great.
Yeah, I think they were definitely like, oh, because kids really do want to be smart. Like, that's the desire they have. And so, anyway.
I agree with you on that one. Rebecca.
Yeah, that's the same. Can you hear me?
Yep.
Okay, great. I'm trying out this new headphone microphone thing. Yeah, that was one that I've also talked with families about before too. Kind of shocked, that it can really affect them that much mentally.
Jefferson.
Yeah, I had the same kind of understanding or two. Without actually 8 points is a lot. I know the sleep apnea and lung issues and stuff like that, but the IQ issue was quite astounding to me, especially if they start early.
And anything that you came forward with that you thought was like a wow piece, though I know you had it, not everybody's in everybody's group.
I just, didn't know a lot about like the long-term use effects. And I think that was the most surprising to me, or just the biggest takeaway. And with it being legal in Colorado and changing throughout the country, I think those are really important things to be able to educate our future patients on.
Marijuana is actually very, very complex medication. And I would encourage you, if you have opportunities to attend any seminars that are occurring in the Denver area, most of them are free, because they really want healthcare providers to get better educated. Every October, is it October? Yep. I think it's every October and November, there's a pharmacology, or it's either in the spring, but there's a huge pharmacology symposium here on campus that is sponsored by the College of Pharmacy and the College of Nursing together. And they almost always have some piece of that seminar about marijuana. And the University of Colorado Research Center, which is located here on our campus, they are the institution that right now is doing the majority of the research on marijuana at the national level. So a lot of the new data related to this particular drug is actually coming out of the University of Colorado, and there's a lot. One of the positions that I hold is an internal medicine nurse practitioner over at Cedar here on the Anschutz campus, which is the drug rehab center. And one of the things that I have found when I'm working with the patients that come in. I do all the H&Ps on these patients. And when you start diving into the history of the individual, you really have to become very specific. And I think, Jefferson, I actually wrote this to you in your response for your discussion from week number 2. I think I actually wrote this to you, that we have to start asking questions that aren't just, are you using marijuana? You say yes. How much are you using? 2 to 3 joints a week. It has to go even deeper, even more finite. Tell me when you first started using marijuana. If they identify that they have, when did you first start using it? Why did you start then? Now, a lot of students in this particular class are FNPs. So we're a mix of FNP and Giro. So for the FNP students, changes are occurring where you actually need to start asking some of your teens and even your pre-adolescent teens, are you using marijuana? Have you used marijuana? Are you around marijuana? And we have to be careful how we ask that in this setting, because the parent is like, oh no, not my child. How dare you ask that question? And they go all defense mode USA, but in actuality, their child is actually using marijuana. Oh, and by the way, they've stolen a couple OxyContin out of the cabinet too. Or they've tried a couple of mom's benzos. And so this is how children are becoming addicted to medications before they're ever 18. And as I read through those articles, something that really was a big take home for me was something that many of you identified, that people will start using marijuana, smoking it, before they ever try a cigarette. Several of you identified that it is a perception that there's less risk of physical harm by smoking marijuana versus smoking a cigarette, when in actuality, that's false. There is as much risk with smoking marijuana as there is with smoking a cigarette. The risk isn't necessarily cancer, but the risk is how the chemicals that cross the blood-brain barrier of the brain actually affect the brain and cause the brain to change how the brain processes memory retention, and how it stimulates other receptors in the brain and can potentiate the development of other addictions. And that's the risk of this drug. And it's not out there being touted. It's being touted it's safe. I put out a challenge question, and not right, not wrong, but this is a question just to keep at the back of your minds. Did the legalization of marijuana happen because it was going to help to actually support the fiscal needs of a state, versus marijuana is being put out there because there's absolutely no risk and it's a safe thing for people to do? So the whys, I think, are going to come out in a couple of years. And don't be surprised if you see some rescindment of some of the aspects of the laws in multiple states as changes are found to the human brain. When I lived in California and I was an ER nurse in California, it was mandatory for us to take classes on this particular drug. We had a big problem with this drug in the area that I happened to work in. And some of the things that I learned from that, I carry over into what I am as an NP. And that drug actually is one of the drugs that scares me so much, because there's so much that isn't known and so much that's touted as safe when in actuality it's not. So heighten your awareness when you're talking to your patients about marijuana. Make sure you go down to when did you first start. So expand out those questions. And that component actually comes under your social history part. You could potentially put it into your mental health part of your ROS, but it actually is a social history piece. But you could put it either place, but just as an FYI for you guys. So great topic on marijuana. We'll do some other things related to chronic pain and addiction a little bit later on in this semester. We're going to move now into genital urinary. Can you see the first slide that says genital uretary? Okay. So it's our virtual week for GU. Some of the aspects that I want to make sure we touch base on and help you guys get a little bit of a broader picture. You've got a lot of readings this week that are really dealing with this. But when you look at the male and the female patient, the two are really different in their presentation. So look over at the male side. There's a whole bunch of stuff that can happen with the male. Now, one of these issues that we have under the male could actually also be occurring in the female, and that could be the incontinence. It could also be nocturia. So both of those could happen in the female as well as in the male. For gentlemen, they can have pain, swelling, and discharge at that penile head. They could have testosterone issues, which we're going to talk a little bit about. Some very common disorders, you guys are well aware of the prostate and the BPH. Now, BPH is benign prostatic hypertrophy, where the prostate gland actually grows, but it's not cancerous. Then we have cancer, which is your prostate cancer. And then we have different types of infections. Something to be aware of is that men don't get urinary tract infections. They just don't get them. Their system is basically a straight shot from the bladder out. Okay, and they don't have to worry about contamination when they do their hygiene after having a bowel movement. But for a female, there's greater probability of cross-contamination from the rectum up across the vagina to the urethra from wiping back to front. And that little piece right there is why women get more urinary tract infections than guys do. So just a little caveat to that one. Of course, guys can have scrotal abnormalities. Now, there's several different types that can occur, and we'll kind of talk about those in just a second. And then, of course, erectile dysfunction. On the females, we have our dysuria, so we have some painful urination. And in that female with that painful urination, we always ask those questions. Do you have any burning, urinary urgency, urinary frequency? Those are your three standard questions that you'll always ask, male and female, if the person is having any bladder problems. You guys were asking those questions as nurses, right? Well, you're going to continue to ask those questions as a provider, all right? But when you're asking about the dysuria, do you have any pain, do you have any burning, any urgency or frequency? The next piece that you have to add on as a nurse practitioner is going to be the questions about, so when is this happening? Every time you urinate, when did it actually start? You have to make a connection in the female to any rough intercourse, because the female can actually get some very small tears that can occur on the labia. They can also occur right at the entrance to the vaginal vault. And as urine comes down, that it's warm, but there's also a pH and there's some acid in it, and it can burn. And so they're burning when they're urinating, but they don't have a UTI. They actually, in fact, have some little micro tears or some actual tears that you can visually see of the introitus on the labia, which is actually causing this feeling of dysuria. Does that make sense? So in the female, we have to kind of expand out our questions a little bit further. Hematuria in the female and hematuria in the male. Okay. Let's do the male first. Hematuria in the male, they don't have a uterus. You don't have to worry about that. So if a guy is complaining that they have blood in their urine, whenever we have blood in the urine, we can have something that is called hemorrhagic cystitis. And the urine is going to look like rusty water. It could smell god-awful. Oh my God, it could be pungent. Very cloudy urine. But it's got a browny red. It could have red. When you see that, and if they've got the urinary urgency, frequency, and burning, they could have hemorrhagic cystitis. You would do a UA, just like you would do anything else, and it's going to come back loaded with red cells. All right? That's a complicated UTI right there because of all the blood. You have to expand a little bit further if you have a hemorrhagic cystitis. You have to go exploring for the pyelonephritis in the guy. Do you have any back pain, CVA tenderness? Remember that your patients are not going to understand what CVA means. They don't know what it is. Do you have any discomfort towards your sides? When I hit your back, percussion, do you have any discomfort? Do they have a fever? Are they nauseated? Do they have any abdominal pain or pain in the front? So there's your linkage there. Okay, let's come back to the female. For the female with hematuria, it's the exact same things we do for the guy, asking the urinary urgency, frequency, and burning, the blood. Now, the blood in the female can come from the vaginal region. And when a woman comes in and they're complaining that they have hematuria, and you get a urine specimen, and you look at that urine specimen, and it really isn't looking browny rust, but it looks bright red. Is the bright red coming from the vagina, or is it actually what they're urinating? So when a woman comes in and they're complaining of blood in their urine, standard of care should also include doing a speculum evaluation, or at least an external evaluation with a hand on the vagina. So not a bimanual, but just a manual exam to see if you get blood coming out on your fingers. My practice is that if I have a woman coming in with hematuria, I get a UA. If it's showing blood when I see it, I'm going to go ahead and I'm going to do a pelvic exam. I will evaluate the introitus. I'll look at the labia. I will do a speculum evaluation, because they may not have any blood that I can get on my fingertips, but when I do the speculum and I can get it down to the os, I can see the blood coming out of the os. Okay? So I need to know, are they on their menstrual period? Very important. So if they're on their menstrual period, do they actually have hematuria? They may not. It actually may be menstrual blood. If indeed my patient is on their menstrual period, I'm not going to do the speculum evaluation. But what I may need to do is have my nurse who's assisting me do a cath specimen instead, because now that blood has actually gone ahead and contaminated the urine specimen, and we really don't know, is it a hematuria or is it not? Does that make sense to you guys? So that's the female component of it. If by chance your female says to you, I'm not on my menstrual period, I'm not, but there's blood in the urine, speculum, evaluate. If you've got blood coming from the os, find out where they are in their menstrual cycle. Is it mid-cycle? If it's a mid-cycle bleeding, could this person possibly have intrauterine polyps? Are they on a birth control pill? Could they possibly be having problems with their pill cycle? So when it comes to that female and that hematuria, things get a little bit more complicated in that female population, because if in fact they're not having blood that's in the urine from the bladder and it's coming from the actual uterus, that changes everything on how we have to work with these patients and how we have to dive into a deeper review of systems and maybe more diagnostics. Does that make sense? Anything that I said confusing to you guys? Okay. I'm taking this hematuria to a different level, to a different medical process. All right. Now we're going to go into the kidney stone. Has anybody that's online right now ever had a kidney stone?
Yes.
Oh, Tara, would you be willing to share your experience with us?
Yeah, so it's actually really embarrassing because I was being a very irresponsible mountaineer, but I was in Boulder hiking, and it was like middle of July, and we did me and my now husband did I think it was like a 12 or 14 mile hike, and there wasn't a lot of coverage at the top of the peak, and we didn't bring enough water. And I got severe dehydration. I was dry heaving, and it was kind of a nightmare. And he had to take me back down. And I got really, really dehydrated. And then because of the severe hypovolemia, I got a stone from it. and it was excruciating. And they wouldn't remove it for like a month because they kept telling me it would pass, and it never passed. So I had to get it surgically removed.
How big was it?
It was actually kind of small. I think it was like 4 millimeters.
What did your urine look like?
It was red all the time, super painful. Yeah, like little spots of red mostly all the time. It was excruciatingly painful though. Yeah.
Jefferson, your mic is on. Did you want to talk more?
No, that's fine. I'm interested, Tara. Thanks for telling us about that. I've never had a stone so far.
You don't want one, Jefferson, believe me.
Yeah.
They are not pleasant at
Sure,
all.
I don't. I stay hydrated.
Yeah, you go, because you're
try.
up at, what elevation are you at, Jefferson?
I live in Denver.
Oh, you live in the Denver area. Okay, I thought you
Yeah,
were up on the mountain for some reason.
I often am. I just got back from Telluride, so I was up there for a week.
Okay, now you made me jealous.
Yeah, that was nice.
Okay, you're going to held back on that little piece of information. Yeah. Oh. Tara, quick question for you. Did they analyze your kidney stone?
Yeah, I think it was calcium oxalate from what I remember. We're going on this was like 5 years ago now, but.
What Tara just said, you guys, that calcium oxalate, that is your most common type of calculi that occurs in the kidney. I will be having a question like that on your examination for these modules. So GU and renal, what is the most common type of kidney stone that a patient can have occur? Calcium oxalate. Now, people can have reoccurrent stones over and over and over again, and there can be a genetic predisposition to them, okay? So when we're dealing with stones, as Tara was saying, they were hoping that it would just pass on its own. Sometimes they don't pass, and they do have to be, you have to undergo a cystoscopy, and they can pulverize them with ultrasound. Sometimes they can't because they're too big, and they have to go in with a Kelly almost, grab it and pull it out. Person's under anesthesia, by the way, or conscious sedation, because when you're trying to pull a stone through a ureter, I want you to think of someone pulling a knife, a sharp knife, across your skin and cutting your skin open. It is very painful. It is a searing, sharp, unrelenting pain from the inside out, like someone's got a knife on your inside and is cutting you inside out. Tara, would you agree with that description?
Yeah, I'm going to be completely honest though. I think, so they placed a stent after they removed my kidney stone, and the stent was actually significantly more painful than the stone.
Good point to bring forward. They can be. That is very true. Very true. Thank you for sharing that.
Sure.
When we have a person with stones, you can see them in your office. You will get them in your office. You can do an IVP. You can do an ultrasound. Sometimes you can just do a flat plate abdomen, and the flat plate abdomen will show a significantly incised stone showing up as a white calculi in the ureter. We can do CTs, and a lot of times we're going to do the IVP, the intravenous pyelogram, as a CT. So we do a CT for kidney stone protocol. It's hit or miss depending upon what your office may or may not have, or what the person's insurance will cover. Just know that. So let's say, Tara, you have another kidney stone. I'm going to use you as my patient. Is that okay?
Sure.
Oh, thank you.
I hope that doesn't happen though.
I hope not. So Tara's in our office today, and she has the pain. We do a urinalysis. It shows blood. 10 to 20 RBCs are present. No bacteria, no esterase, no nitrates, but it shows the blood. So, and it may have maybe 2 to 4 WBCs. You could still get WBCs. That's not a urinary tract infection. Her symptoms are the pain, the back pain. She can feel it. Sometimes you'll actually feel the pain in the front, and it'll be coming around like where the love handles would be on the human body. So coming around on those hips, on the pelvis. In the female, it literally sits right where the ovaries would be. So is it ovarian pain, or is it actually the ureter pain, kidney pain? So it's kind of asking those questions and then doing your exam. On the guy, it's a little bit easier because they don't have ovaries. So you have to, find out where the pain is at. If they're saying their pain is in the front, the kidney stone can have come from the back through the ureter and hit the jux, and it gets stuck in the bifurcation between the ureter coming down. There's like a big curve that it has to make to come down and dump into the bladder, and at that curve is where it can get stuck. So their pain won't be in the back, it'll be in the front. So that will happen that way too. So we know that Tara's got her kidney stone. We want her to push fluids, a lot of fluids. I'd like her to drink at least 2 to 3 liters of water a day or a beverage a day. I don't want her drinking coffee or tea. She can drink Gatorade. She can drink flavored water. She could drink our sparkling waters if she wants. But I can help her. I can give her some Flomax to help with relaxing the ureter so that it can actually quit gripping it and try to let it slide through. We can use Ketorolac. So if the person's in your office, you can, if they're young without any kidney failure, you can do 60 milligrams of Ketorolac for pain. You do not have to use a narcotic. You can use Ketorolac for that. And we can also prescribe Ketorolac for them to go home. So we can use Ketorolac to go home. We can use a little Flomax. We can have them use ibuprofen or Tylenol too. All right. So we can do all that. Let's say Tara did not have to have a stent. She didn't have a cephalocystose. She is able to pass it. You want to give that patient instructions that you want them to bring that back in for analysis. So that means when you discharge your patient out of your clinic, that you need to send them with a strainer, a urine strainer. And you need to document that the patient was educated on how to use it and that one was given to them and that they were educated on to bring the stone back. Now, when the stone comes out, did you ever see your stone, Tara?
No.
Okay. It looks like a piece of a bone chip. They're pretty, they're not opaque. They're kind of whitish, kind of gray-white, cream yellow-white. They're very irregular and they're sharp. That's why they hurt, is because they're sharp. They're crystals. And when it first comes out of the human, that's what it looks like. But as it begins to dry, it looks like a piece of gravel. So I have had patients come into my office doing Munchausen's. They want to be ill. And they brought in a piece of gravel off the road and said it was the kidney stone that they passed. Well, we sent that kidney stone for pathology and it came back being quartz. Your body can't make quartz, okay? No, it can't. But I tell you this because patients can do this. Patients want to receive narcotics, those that have an addiction and they're hiding it. And a kidney stone and a presentation of a kidney stone, treatment in an ER and an urgent care typically does include narcotics. We're trying to move away from that. So a patient could present and what they're really seeking is drugs. And they can poke their finger, they can bite their fingers and drip their blood into their urine in the bathroom. And it comes back being positive for blood. You are saying, well, they got blood in their urine. Do they have a kidney stone? And in the meantime, you're giving a medication that are narcotics. So move away from that. Ketorolac works really, really well. Does a great job on the pain. You do not have to give a narcotic for this. My daughter had a kidney stone. It was a honker. It was a big one. And I refused to allow her to go to the emergency room. I swear to God, she was going to kill me. But in the emergency room, that's almost a $25,000 bill. Because they're going to do a CT, you're automatically getting IV fluids, they're going to give you IV push medications, physician costs, lab costs. Now you're at $25,000. She's going to pass it. So I gave her some Ketorolac, gave her some Flomax. It did pass in 3 days, but she swears to me that she will never love me again if I do that to her again. Hers was stuck at that juxtaposition with a curvatus between going down to the bladder and coming from the kidney. It got stuck there. And when she showed me her stone, it literally looked like a sickle with an extremely sharp point. and then small little barbs coming off the side. Very, very painful as it was moving through. Hers was about 4 millimeters too, Tara. So moving to the next step, your patients should pass these kidney stones. And they usually pass, once they start moving, they usually pass probably in about maybe 5 to 12, maybe 14 days. You do need to bring your patient back into the clinic to be seen and evaluated. If the patient is still having symptoms, you may need to send them on to your urologist, okay? Now, with the pyelonephritis, with the kidney stone, and with the symptoms of hematuria and a UTI, people can develop pyelonephritis, which is an actual infection of the kidney itself. And that can be a very painful, but it could also make the patient quite sick to the point that they can become septic. So when you have a patient with pyelo, how do you know the difference? And this could be male or female. They've got a fever. They look acutely ill, nausea, significant back pain, and they may not be able to keep their oral antibiotics down. You may have to actually have them admitted to the hospital for at least 24 hours to 48 hours of IV fluid and antibiotics. If they're nauseated but not vomiting, you can manage them on an outpatient basis. You're going to need to go with a higher end medication as long as they're not allergic. So your ciprofloxacin would be our drug of choice. Because it is a pyelonephritis, a more significant infection, it's not going to be for 5 days. It's probably going to be for 10 to 14 days. And then you do have to have them come back. Let's say, Tara, I'm going to use you. Your kidney stone came out, but you got a pyelo right after it. And you're sick, 102.4 fever. You're grossly nauseated. You're pale. You're in a lot of discomfort. I give you the option of being admitted to the hospital or going home. You want to go home. Now, here's where really, you have to really educate very strongly, okay? Educate on the antibiotic. Make sure they're able to take it. Tell them if you're not able to take it, you have to recontact me. And we may need to send you to the emergency room because this infection can wind up making you very, very sick. You have to be clear on that. You want to discharge them with instructions on what to do. If they can't get their meds down, that's going to be going to the ER. About fluids. You're going to discharge them home with an antiemetic, something that they can take. If they are really nauseated and they can just get one pill down, you can go with a suppository. And you can give them like a compazine suppository. You can give the ODT Zofran where it just dissolves in their mouth and they don't have to swallow. But you need to not just address that they have this infection, you have to address the nausea as well and medicate them for the nausea as well. You want them back in your clinic within 24 to 48 hours for reevaluation. What you're evaluating is their whole status. How is your nausea? How is your pain? Where is your fever at? That fever also needs to be included in your discharge instructions with Tylenol. So switching between Tylenol and ibuprofen, and that they can do that. If they are unable to manage their fever and it continues to go up even with this regime, automatically to the ER, okay? This little piece right here, this pyelo piece, this is some places where I've been, when I work as a legal expert for the lawyers, people who've come in with sepsis and then they go into organ failure. This is where I see the lawsuits come through. It doesn't matter. Usually I see it with an older patient, but I've had a couple come across my desk where the patient was in their 20s and their 30s, where the NP did not provide clear direction on what the patient should do, especially that follow-up. Patient didn't follow up because it wasn't there. I think the NP had written come back in 5 to 10 days. Patient within 48 hours was septic. 72 hours they were found almost comatose in their home, transferred to the ER. They were in septic shock, wound up in the ICU, wound up in organ failure, wound up on neo, and the patient wound up losing some toes because of the neosynephrine. Wound up being a major lawsuit. If the nurse practitioner would have just written, I need you to come back in 24 to 48 hours, call me if symptoms get worse before this time, this could have all been negated. Does that make sense to you guys? So I want to provide you not just what this is the care, because you can read about the care, but some of these small little nuances that I know that occur with practice, I really want you guys to get those small nuances before you get into practice, so that your level of practicing is a little bit higher when you get out. Any questions on this so far? Okay, we're going to go back to the guys now, because we've talked a lot about the hematuria. We're going to talk a little bit about UTIs in just a second or two. For the incontinence for both men and female, this is something that can happen with age. So you just have to gauge how bad their incontinence is, and we do have some incontinence tools that we can use to measure how much they're having problems with. Females have a tendency to have more stress incontinence. Guys have a tendency to have more incontinence problems just in general as they get older. The nocturia, this is going to be something that you want to be monitoring for congestive heart failure with, because if people are holding on to fluid during the day and they lay down and they're supine, they're better able to bring those fluids back, get the blood around and circulate, and the kidney is better able to actually remove those extra fluids, so people will complain of nocturia. So nocturia is usually associated with another disease process, not necessarily a genital urinary process. Voiding difficulties, not so much for females, but more for males. And when guys start complaining of having voiding difficulties, we start looking at the prostate gland, that there may be some enlargement there, and that's what's causing the problem. So for the guy, it's really important to ask, are you having any problems starting or stopping your flow? Make sense? Because that's going to tell you what's happening with these guys. To evaluate a guy's prostate gland, you can actually do a rectal examination. I can tell you that when I first started practice, I was clueless as to figuring out, am I actually touching that little fella up there? But I tried on every guy I had to do a physical on, and pretty soon I began to figure it out, because I had guys that had big guys. Their prostates were like the little size of golf balls, and it protrudes into the rectum. So basically, ladies, if you just look at your hand and look at your dominant hand, so if you're right-handed, look at your right. If you're left-handed, look at your left. We have a tendency to use our index fingers to do our digital rectal exams. So look at your finger, look from the top of your finger down to where it connects actually into your hand. That second knuckle down, that is about how far you will insert your finger, and you rotate it up so that the tip of your finger, this part right here, is pointing towards the patient's spine. Push it up a little bit further so you're beginning to feel the rectal tissue right in this area here. So you're all the way into the rectum to the second knuckle. And when you get past that and you're sitting with the rectal tissue right about here on your finger, touch the tissue of the rectum and push in. You typically will feel nothing. But if you feel something, that is the prostate gland. We typically should not feel the prostate gland, but if we do, it's enlarged. Okay? We can run a PSA, which is your prostate surface antigen. It's going to tell us if this person potentially has prostate cancer, but it won't tell us anymore. If we find that there's an enlarged prostate gland, do we have to do anything about it? No, not unless it's really causing the patient problems. Okay? And if the patient is having problems with that, then there are some of our medications that we can use, like our Flomax, that we can help so that there's relaxation to allow the urine to get by. Sometimes we're going to refer them to urology because we're not going to manage it. We need them further evaluated. They have a family history of prostate cancer. Just shift them right on over to urology. We talked about guys don't get infections. We live here in Colorado, and this is an extremely health conscious state. And there is a very large population here in Colorado that the individuals, male and female, do weightlifting. Weightlifting individuals, especially males, have a greater potential to get a urinary tract infection because of the intense change that they do to the intra-abdominal pressure, when they are lifting heavy weights above their head. You guys have seen the weightlifters, they put the belts around their abdomens and they cinch them tight to help so they don't get a hernia. When an individual is lifting weights above their head, so they're doing an overhead press or a clean and jerk, when they're doing that, for the gentleman specifically, the change in the intra-abdominal pressure also causes changes in the pressure of the bladder, and it affects the sphincter. When a gentleman urinates, they usually urinate out and they shake a little bit, get the rest of the urine, they're done. But there's always a small amount of urine that remains within the urethra of the man that doesn't come out. It just kind of sits there. It doesn't leak, it just sits there. When they're ready to void the next time, it comes out. Nothing ever happens. But when you got a guy that's doing these weights, they can get a reflux. So the change in the intra-abdominal pressure causes a change in the bladder, and they're pressing down, and then when they come up, they release that pressure. They can actually suck urine back from the urethra through the sphincter back into the bladder, and that can cause a urinary tract infection. Make sense? This wasn't in a book. I had to figure this out all on my own on practice, and I couldn't figure out why these really young guys kept coming in with urinary tract infections. Well, then I started doing the research and learned weightlifters, I have to ask, are you lifting weights? Because guys don't get infections. So a pearl I share with you, when you get a gentleman in, don't let age be a deterrent. Always ask, do you do any weightlifting? If you do you do any overhead presses or clean and jerks? Ask the questions. Don't be surprised if they say yes. It's like, dang, this could be it. That is that type of infection in a guy, we're going to need to treat a little bit more aggressively. So it's going to be about 10 days of treatment, not a 5-day treatment or a 3-day treatment. You need a little bit more aggressive because by the time they come in, it's probably more advanced, just as an FYI. Scrotal problems. Guys can have birth defects in their scrotums. They can also have growths that occur in their scrotums. Gentlemen sometimes will find that one scrotal is larger and the other one's smaller than the other. There could be a genetic component where the actual epididymis did not come down properly. Sometimes you can find that gentlemen have lesions on their scrotums. Sometimes these can be related to sexually transmitted diseases. They look like little ulcers, and it could be a sexually transmitted disease. You have to palpate and touch. You've done the assessment. You know how to do the assessment. You were taught it in your advanced assessment class. Seeing it and doing it on the real human are real different. Those little testes, you guys, they are so sensitive and they're so delicate. So you don't have to have like mashy hands. You want to have gentle hands, just like you were touching a baby. Because those poor guys, we don't like our breasts smashed on a mammogram. They don't like their little testes smashed when you're doing your scrotal exam. I have found that if I close my eyes, I can actually feel all the elements of the testy much more clearly. My eyes open distort what my fingers feel. I do one testy at a time, and they should feel equivalent in size and texture. They are a little spongy, and they're not like hard like rocks, but they are spongy. And I should not really feel anything. You're going to feel the little hair follicles and stuff like that, but underneath all that should feel pretty smooth and without any swelling. You shouldn't feel any like Rice Krispies, like subcutaneous emphysema. You shouldn't feel anything like that. It's all smooth and they feel kind of spongy. They're usually equal size. It will be slightly tender, but it shouldn't be grossly painful. And if it is, you may need a testicular ultrasound. If a gentleman comes in complaining of severe testicular pain, first thing you need to think of testicular torsion. And they need to have an ultrasound. That is a medical emergency. If they have a testicular torsion, they could lose that testy and they need immediate referral for surgery. You can actually send them to the ER and the ER will get a urologist involved for this surgery. You could contact a urologist and say, hey, this is what I have. How would you like me to work with this? 9 times out of 10, they're going to tell you to send them to the ER for treatment. Erectile dysfunction. With erectile dysfunction, there's a lot of things that could cause this, but your two top, diabetes type 2 and 1, and number 2 are going to be people who have hypertension and have cardiovascular disease. Those are your tops. Top 1, diabetes. That, I have my students that graduated in May, and I have students that have graduated in August, and they're now taking their boards. And the ones that took them and that took them in August have told me that they had that question on their exam. And the ones that took it in May told me the same thing too. That a patient presents with erectile dysfunction, the nurse practitioner needs to make sure that they evaluate for type 2 diabetes, was the actual answer. So just giving you that FYI. So that's a lot of information here, isn't it? I know. GU is not boring, not at all. So let's go to our next picture. So testosterone deficiency is something that a gentleman could come into your clinic and complain of. They could. I'm not saying they're going to, but they can. And this is kind of writing a ridge on, do you want to really deal with this as a nurse practitioner, or do you want to send them on to endo? We don't get a lot of education about testosterone deficiency in a guy, but I wanted to make sure that you had a better understanding. So the picture to your left is the clinical picture of what they're going to present with. Notice what's in red. We have erectile dysfunction that can occur, and we've got loss of libido, loss of sex drive. Okay? But look at all the other types of things that the person could present with. All right? So there's a lot of things that a person could have, but we may not necessarily correlate them to testosterone deficiency. It's kind of like low down on my differential list, something I may think of later. Guys normally don't come in and say, hey, I think my lipid is related to my testosterone. We find that as a secondary cause. Looking at the darker picture, which is your target organs, this is why people typically will seek treatment. They want to build muscle mass, so they want to have testosterone given to them, so they have bigger muscles, they look stronger. A guy needs testosterone to support their kidney function. They need it for their bone marrow. They need it for their bone. They need it to maintain their gonads. For liver, they need it for their synthesis of proteins, and they need it for their hair and for their skin growth. So guys, the guys will typically come in because they don't feel satisfied with the sexual experience. They may not be having an orgasm and they think they need testosterone for it, or they want to bulk up and they want testosterone to bulk up. So those are the two reasons they usually present. Well, there's very specific things that we need to do before we start looking at testosterone being the problem. So this is actually the 2015 guidelines for testosterone deficiency syndrome. So I wanted you guys to have these, and I'm going to post these slides for you guys just right after we finish talking, so you'll have this. So suspicion of somebody getting testosterone deficiency, if they have type 2 diabetes or insulin-resistant diabetes, there's a whole bunch of stuff listed here that could lead us to think maybe this person has developed it or is developing it. So if I think that as a nurse practitioner, I would want to draw a testosterone level. Notice what it says here. These levels must be drawn between 7 a.m. and 11 a.m. in the morning, or within 3 hours of waking by the individual. Otherwise, you're going to get results that are not appropriate and actually can be skewed. So this is when a male's testosterone level is actually at its apex or its norm of what they actually have. So you have to have this. This will be on the exam. All right. What is the most appropriate time for the nurse practitioner to order testosterone levels to be drawn? So I'm going to put that in your exam just so you know. Okay. Okay. So let's say it's normal. They don't have it. They don't have testosterone deficiency. If it's low, we have to go find out why. So then we have a whole gambit of tests that we'll need to run on this individual. What if it's borderline? Now what do? We're going to refer them to an endocrinologist. Okay. I know that there are freestanding clinics out there called NuMale. We're not going to refer them to NuMale. We are going to refer them to an endocrinologist. All right. So a couple things can show up. One, they could have primary hypogonadism. And what is it? It's a low testosterone and a high luteinizing hormone and follicle stimulating hormone. So they actually have more of a feminization than they have masculinization. They can have secondary hypogonadism. This is going to be a pituitary hypothalamic dysfunction. And let's say you don't really understand. It's not a clear picture. Don't try to figure it out. Send them on to endocrinology. Okay? Anything here not make sense? I think it's a really well-designed guideline to follow. And it's very clear. I think the most important piece is this piece here, because if we don't do this right, the rest of these tests could be misinterpreted.
I have a question, Dr. Paxton.
Yep, go ahead.
What do you consider, or what is considered borderline low?
The borderline low numbers, I don't know the exact number in my head. I'd have to go look it up. But it would be one that would, let's say, be just one under normal.
Okay.
Like 0.01 under normal or 0.02 under normal. I don't have my testosterone levels memorized in my head, but when I would look them up or refer to the lab value that would come on my paperwork or on the computer screen, if it was just a little bit low, just like 0.01 or even just 1 under, so it's borderline if they are or they aren't. Let's say it was like 4 or 5 less than what it should be. That's clear that it is definitely low testosterone. But when you're just getting to those, it's just 0.01. Is it or isn't it? That would be borderline. Does that make sense?
Yeah.
That's a really good question, Tara, because that applies not just to this, but to a lot of other medical problems. So if a person is hyperthyroid, but they're 0.01 showing it, are they really hyperthyroid?
Mm-hmm.
Some would say it doesn't matter. Under is under. But others would say, well, they're just barely there, so they're borderline. Does that make sense?
Mm-hmm.
You have to use your clinical judgment on this and also the symptoms that the patient is presenting with. So what is the person concerned about? What are you finding with the ROS? And what did you find with your physical exam? Do you see how that works with interpreting the labs? That is how we have to do it. Because if we just went off of a number, we forgot to look at the patient. And we don't just treat a number, we treat the patient, right?
Right.
So that was a really good question. I'm glad you asked that. Thank you.
Thank you.
Oh, you're
Dr.
welcome. I didn't
Paxton.
confuse you, did I?
No, that makes sense. It's
Okay.
a lot like with thyroid, right? So like
Yep.
if the TSH level, is, I don't know, every lab is different now, but
Yes.
if it's above 5, some places always treat. If it's above, some places don't treat until it's way higher than that, and some treat if it's above 2.5.
Yep. You're right. So it is. It's a quandary.
Okay, thank you.
Yeah, you're welcome. Joy.
Yes, I just have a further question. You were talking about referring them on to endocrine, and I know that practice looks very different than sometimes school. So I had a preceptor that did manage this like completely on her own.
Excellent.
But and then also in our last module, you were discussing like bipolar. All the recommendations were that we should not manage my bipolar. It needs to be addressed by
That is
a higher
correct.
level. She also addressed bipolar in the clinic. So I just wanted to see, like on her own. So what would be your
What clinic are you at?
Oh, this was previously.
Oh,
It was a
okay.
standalone clinic, a primary care clinic, and it saw only Medicaid patients.
Okay. And these are good questions, Trace. I appreciate you bringing them forward. As you get into practice, you will decide what you want to manage and what you don't want to manage, okay? If you choose to manage a bipolar patient, for instance, then you need to make sure that you understand all of the elements that are included with that, including the legal ramifications of it for potential lawsuit. Okay? The same thing occurs for testosterone. The bipolar one, we get, as nurse practitioners, we get some training, but I may not feel I have enough training. And in order for me to feel comfortable managing a bipolar patient, I'm going to go get more training to be able to do that, and then I'll feel comfortable. Okay? This is completely in your wheelhouse. The recommendations that come from the guidelines state that it's best practice to refer.
Okay.
If the practitioner makes the decision, you know, I don't really need to refer this, I can do this, then that's their decision. For the testosterone one, again, this is coming off of a guideline, and that's what I have to speak to. Going, let's say, like off-label, I could probably manage this in my clinic, but let's say I started to manage it and I wasn't getting anywhere. Do I continue to try to manage it, or do I shift them over to endo or possibly even GU? But it's going to be an endocrine problem. And when I talk to my endocrine specialist nurse practitioners, they tell me, you know what, Kim, don't even try and do this. It can get so complicated and it takes up your clinic time trying to do it. Just send them to us. That's what we do.
Okay.
And so bottom line, I can make these statements and you will find, as you just did, that you've got a practitioner that is completely opposite of what I said, and that makes you confused. That is their choice. And if they're teaching you how to do that, that's a fantastic thing to be able to do. And I would support, if you want to do that, do it. But understand how you open yourself for legal lawsuits if you don't do it right and something happens, especially when you don't really feel that your training is strong enough. And it's something where somebody could possibly do self-harm, like suicide. Okay, so just be careful with that one.
Okay.
I'm not saying don't do it or do it. It is your choice, and you will decide what you want to do in your practice. I bring forward the guidelines.
Thank
Now,
you.
Dr. Paxton, would we find that you send them to the endo or the mental health nurse practitioner, they come back, would you refill their prescriptions that they were prescribed by another practitioner?
When you typically refer an individual out, what typically happens is that consultant will see the patient and they will send you their write-up of what their plan of care is. In their plan of care, they may say patient is to return to primary care for continued management after initiation of treatment. It may say recommended that patient return to endocrinology for further follow-up. That patient is either going to decide, you know what, I want endocrine to manage, or the patient's going to decide, I want primary care to manage. The patient, typically once they see a specialist, will stick with the specialist for follow-up of that disease practice. Sometimes people with thyroid problems, once they get managed and they are managed well, that specialist costs a lot of money. So they will then come back to primary care and be managed by primary care. Some of the more complex endo problems, they won't. They'll stick with their specialist for management. That's a really complex question, Rebecca, but what I just gave you as an answer is what is typically seen in practice. Okay, does that answer your question?
Yeah, it does. I've been at I've been at Salud and Clinica, and they'll go to the specialist, but they really want the primary care. I think maybe because the copays are cheaper and all that. They want them to then prescribe those medications for them, even if like Adderall for ADHD and things like that.
Once they get the patients managed and the patient is good and they've got them they've been good for 6 months, primary care can manage this and we're not changing anything. Definitely they can do that. And a lot of clinics do. It's up to how clinics want to practice, depending upon where that clinic is. One of the things that I'm finding is that there is a greater push to have specific disease processes shifted back from specialty back over to primary care. HIV, they're really pushing HIV to be managed in primary care. They're pushing for thyroid to be managed in primary care. They're pushing for BPH to get back into primary care and be managed after urology has figured out, what the problem is. They get them on the path to fix, go back, primary care can do this. Because a lot of times all primary care is doing is the monitoring. And if everything's coming in the normal parameters of what they're supposed to be, it's just a renewal of an RX and then watching for any side effects or adverse reactions. So that really can be managed in primary care. Again, going off of what Joy had asked, it is going to be your choice as the practitioner and you being the provider, what you want to manage in your clinic and what you don't, and what you want the patient to continue to see. And that one, I can only provide you with antidotes because it's what you believe and what you feel and what you feel comfortable with. That is the hard part of you starting into practice. Does that make sense? But as you progress through this class and you get into your Gero class and then with your practicum courses, hopefully some things will start to come forward for you that you begin to feel, I can do this. I'm okay with this one. No, I'm not okay with this one. Like derm and removing some derm lesions. I'm not comfortable with this complex lesion. I can't do that. No, I'm sending them to derm. Always, I plant this seed, always err on the safest way to manage the patient and to keep yourself out of litigation because you practice above what your education level is, what your competence is, and what your skill level is. Does that make sense? Okay.
Yes.
All right.
You.
I know. That was such a good question, Rebecca. Oh my gosh, you got my brain going here. I want to answer these differently, but I need to be honest with you guys. It isn't always black and white, cut dry. It isn't. I wish it was, but it's not. Okay, the next one was the question that was coming up this week for our discussion on dysuria, giving you those top differentials. Make sure you're looking at the elements that are coming forward, okay? Then you're going to take this and move this into an individual, the individual that you're doing. And then you have to fill in your PBL. Now your diagnostics, somehow my link broke, but I've got it reconnected. I reconnected it, I think it was Sunday afternoon or Sunday morning. So you should be able to see those. Make sure you look over them very carefully. Be succinct in going over those labs. I would print that page and I would highlight anything that you find to be abnormal. Okay, and I'm going to go back to what Tara had asked about, okay, what if it's just like one under what it's supposed to be, a one above what it's supposed to be? That's your clinical judgment call. Take that clinical presentation diagnostically wise, compare it back to what you're seeing with your patient and what your patient's reporting. Start doing the application. That's the clinical reasoning part. It's hard. And this is one of those where you may have to do that a little bit. And then give it your best shot. Okay? Any questions about this so far? Awesome. All right, I'm leaving you with my owl. So, little inspiration. Knowledge is knowing what to say. Wisdom is knowing when to say it. So, great questions today. That was you guys producing wisdom and saying the pieces that you needed to say to get clarification. So, thank you for those. I'm benefiting from them. The students that will listen to this later today or tomorrow or the next day will benefit from them too. I don't have anything more yet for this particular session. Any questions, any concerns? Y'all good? I know you're just dying to get to that PBL. I can just see it in your faces. All right. You guys, thank you so much for joining me today.
Thank you.
Thank you.
Bye. Hey, Ellen.
Hi.
It's good to see you. Oh my gosh. By the way, I'm working on your spring placements. So if you have any specifics besides what you sent me before, shoot me off an email because I'm almost got your guys' group done. So pretty close to having them done. Okay. So shoot me off a text or an email if you have anything specific that you didn't send me before. So see you later, guys. Have a great week, okay?
Yes, bye.
All right, bye.
Bye.